Hello, everyone. Welcome to the Vanderbilt University Medical Center's Geriatrics Facet Curriculum video series. Today, I have Dr. Duggan, who's the Geriatrics Program Director and attending on the ACE unit, Mallory Bryant, who's an intern here at Vanderbilt as well, and then myself, Thomas Horton, who's PGY3 internal medicine here. So today we're going to be talking a little bit about urinary incontinence, Foley management, and all of those spectrum of kind of things that we look for from a urinary issue in some of our geriatrics population. So Dr. Duggan, is this something that you were formally taught throughout fellowship or even in residency training here?
Yeah, we focused on it a lot during fellowship. You know, in fellowship, we think of within inpatient care, we have these hazards of hospitalization. And hospitalization is really dangerous for older adults. They may walk in with a pneumonia and leave with cognitive impairment, inability to walk, inability to void on your own. And so everything that happens in the hospital, we need to be aware that it's potentially hazardous to older adults. And Foley catheters are one of those hazards. And if we need to place them, if they're indicated, you know, we do so. And we just need to be cautious that we're not over placing them or not pulling them out as soon as we can, because they are a risk factor for developing delirium, for causing injury. If you have delirium, you pull out the catheter while the balloon's inflated. And for possibly for falls, getting tangled in the catheter, right? And patients don't usually like them either. So if we can, you know, prevent them from being placed in the first place or remove them as able, that would be ideal.
Absolutely. And, you know, in thinking about certain indications of, you know, an in and out catheterization versus, you know, a leave-in Foley, what are some of the things that kind of delineate the two for you, Dr. Duggan?
Yeah, so for me, so we have acute urinary retention, right, happening over days, chronic urinary retention, commonly from things like BPH in men as they age. And those two are kind of treated differently. In the hospital, we often deal with acute urinary retention. And there are many different causes of acute urinary retention, right? And if the cause is something that we can fix in a pretty short time frame, I definitely go to the in and out caths. Even if I'm not sure, I'll try the in and out caths before sort of claiming defeat and saying, okay, this retention is going to last for a while. Let's go ahead and place the Foley. There are conflicting data about infection risk with in and out caths versus indwelling Foley catheters. I wonder, Mallory, in your sort of experience as a resident so far, have you been trained about one or the other? What's your experience with sort of thinking about how to prevent UTIs in people that have acute retention?
Yeah, formal training isn't coming to mind, but just like anecdotally, I would say if we're worried about infection risk in someone, there's something, and it might just be some line of logic somewhere that the in and out catheter would be less infection risk because you're not putting something there and leaving it for a long time. And it's not like placed and forgotten about, but I'm not sure there's any evidence or data to kind of back that up.
Yeah, that's the common practice that at least, you know, our group uses, is if we can get away with an in and out cath, let's do that and avoid the Foley placement. The urologists tell me the bladder goes to sleep when you place a Foley catheter. And if you do in and out caths, it gives the bladder a chance to wake up and use its muscles. I don't know if that's true, but I really like the thought of helping. Yeah. Like, all right, we're going to wake up the bladder because we also like to wake up our patients in the morning to avoid delirium, right? And in terms of sort of your threshold for when to place a Foley or when to catheterize or not for retention, you know, that can vary. Most common reports for males are that retention is defined as about between 100 or 200 cc's in the bladder. And for women, it's actually above 200 cc's. And if folks have chronic retention, their volumes may be larger and they may not be symptomatic. And so that approach is taken differently, usually in the outpatient setting with urology. And so, we take into consideration how much volume is being retained. We take into account a patient's own wishes about catheters and in and out casts. Sometimes it's just not practical to send someone home to do in and out casts if they live at home and they're disabled and they have arthritic hands and they're not able to do that, right? So sometimes it's just sort of a logistic determination. The logistics factor into that determination of in and out versus Foley catheters.
Absolutely. And do you have, in kind of assessing acute urinary retention or even some chronic or subacute urinary retention, I think it definitely depends on the patient's ability to express their symptoms, rather, if they feel like they have suprapubic tenderness or, patients who struggle with dementia and things like that, that might be a little harder. Do you have, Dr. Duggan, prefer, a post-void residual measurement versus just a bladder scan? And how do you kind of navigate which one should we be ordering at what time?
Yeah, I usually start out with a bladder scan. Some scanners are more reliable than others. If there are clear signs that we're having retention, if the patient's symptomatic, then and the bladder scan is low, then we may try an in and out cath and then see what that volume is when we place the catheter.
I see. And then something that I learned throughout my training, and Mallory, I'm sure you've probably picked up on this as well, is that in some of our patients with cirrhosis decompensated by ascites, the ascites actually can throw off the nurse's bladder scan measurements. So it'll actually be assessing the acidic fluid volume rather than the bladder volume, which point, we might need to use our own ultrasound skills to kind of determine the volume of the bladder. So that's one thing that I never thought of until I actually came across that in patient care.
Absolutely. And some old school geriatricians can palpate the bladder and feel if it's mildly distended or not. I haven't acquired that skill yet. I'm still working on it.
That would be amazing. I will strive to do that as well. And then what other, aside from acute urinary retention or discomfort for patients, what are some other indications, Dr. Duggan, that we would be able to or utilize the Foley catheter to, hopefully risk-benefit ratio?
Yeah, so we see catheters appropriately placed for patients who are critically ill and needing really accurate measurement of their urine output. Also in the operating room, Foley catheters are placed appropriately so. And then post-operative, we try to remove the catheter. And I think it's important to think about pressure injuries. And when we have more advanced pressure injuries, stage 3, stage 4, and there's incontinence going on, then it can be helpful to place a Foley to keep that wound bed on the sacrum, keep that wound dry so it will heal rather than the dressings getting saturated. So that's the one time really when somebody has like chronic urinary incontinence that we would recommend placing a Foley as that sacral ulcer heals. We also use catheters at the end of life, right? For comfort, for patients who are actively dying. And I'll say this list is not all inclusive. When urology tells me to place a Foley because of a urethral stricture or because of hematuria causing, obstruction, I do what they say. And so, but these are the common things that I will place Foleys for. Acute urinary retention, ICU, peri-op, incontinence with a pressure injury, and end of life.
Absolutely. That's really helpful. And I think sometimes, at least we forget when we are making, more comfort oriented goals. That's one of the things I usually forget, but definitely a good reminder just to optimize their comfort while they're here with us in the ACE unit. Awesome. Melanie, do you have any other questions or pearls that you'd like to ask Dr. Duggan before we close out here?
That's a great question. I guess how I think one of the things that I get asked the most is like I'll get a page like, hey, can we place a Foley for incontinence? So how do you balance like in the acute hospital setting, kind of the infection risk that comes with a Foley versus like potentially exacerbating pressure wounds and different things like that from incontinence?
Yeah. So great question. We commonly see incontinence in the hospital. Sometimes it's chronic. Sometimes it's new because of a medical issue. Sometimes it's new because it's functional incontinence. They're just laying in bed. They are placed on bed rest and they can't get up and go to the bathroom. So they have an incontinent episode. And so kind of teasing out, what's at the root of this incontinence? Is it something we can address by scheduling toileting every 2 to 4 hours with a nursing assistant so that we're not having incontinence in the bed? If it's not that easy of a low-hanging fruit, perhaps there's medications that are contributing to incontinence. Perhaps there's retention going on with overflow incontinence. And so I think these things and sort of the differential diagnosis for urinary incontinence are helpful to think about as you sort of address it. So, you want to think about the underlying reason. Why does this person have incontinence? And target those risk factors or those etiologies as you can. In terms of the incontinence management, right? Incontinence kind of never hurt anybody. I mean, unless, right, obviously it does increase your risk factor for, I'm gonna retract that statement. Incontinence is a very important public health problem that affects many people and causes a lot of depression and poor quality of life. In the hospital setting, we can manage incontinence well with barrier creams. And so what we have our nursing staff do is apply barrier creams generously to the sacrum and schedule voids. So get them up, void them, or get them to void as often as we can, every couple hours or so. And if there is an incontinent episode, we just wipe off that top layer of the barrier cream and reapply more. So that approach has worked fairly well. And I think for some, maybe if a nurse calls us about this, we can do some education about some alternatives to the Foley catheter.
Great.
I thought you were going to say, what happens when the patient requests it? We have some providers who are very strict on this is the only indication. I don't care if you want it. I don't care if it makes you feel good. It's going to increase your risk of infection and I'm not going to do it, right? And then we have other providers that are like, well, patient satisfaction score, patient-centered care, they're accepting of the risks. Let's go ahead and place it. And so I think you need to probably meet somewhere in the middle and hear your patient's concerns and educate them about those risks and try to perhaps negotiate as you can to come up with the best, answer. I would say personally, if it's, they're going home with hospice and they want one, absolutely. I think if it's somebody who we've tried everything and, they can't do the I&O caths, or it's hurting when they do the I&O caths, and it's really causing distress, discomfort, then I think it's okay, appropriate to leave one in place.
Yeah, that's really helpful. One question that I thought of while you're discussing that, Dr. Duggan, is there any difference in kind of deliriogenic risk with patients who have condom catheters who might not, qualify for this incontinence, condom catheters versus PureWicks or like urinary suction devices?
Yeah, great question. I have not seen any studies on that. So I don't know that there are data kind of comparing those options in terms of delirium risk. That would be an interesting study to do, though. Yeah. I'm guessing there's not much of a difference. They're all, a PureWick is, from what my patients tell me, the PureWick is fairly, comfortable and fine.
Yeah.
The condom caths can cause problems. They can cause they like get like twisted and cause
Yeah.
damage to the penis and injury there. And so I try to avoid them. And the ID docs tell me they increase the infection risk almost just as much as the Foley
I have
catheter.
heard that as well. Yeah, I have heard that as well. So I've, initially, I think I was placing more of them because I thought, they wouldn't be leave-in Foley catheters, but now, just as to your point, I think I try to avoid them and really try to optimize the skin kind of prevention of injury, even if there is incontinence in the inpatient setting, which is great.
And this really ties into one of the 4M's, mobility, right? So yeah, it's easier to lay in bed and have your urine, taken away by these devices. But we want to get patients up out of bed. We want to move them and get them to the toilet, right? And so that's promoting mobility. And patients may not want to, but once you explain to them, hey, for every day you're in the hospital bed, it takes at least a week for your body to recover and regain its strength. And I know you told me you want to be strong so you can continue taking care of your grandchild at home, right? So let's work towards that. Let's work towards regaining your strength. And part of that is going to be you getting out of bed to the commode with assistance, but working on strengthening you that way and trying to not stay in bed all the time.
Definitely. Yeah, that's helpful. Well, this has been really eye-opening for a couple different points. I'm just going to summarize for our listeners and watchers some of the things that Mallory and I have learned today. So some common indications for these Foley catheters are, acute urinary retention or inability to void, the need for, potential accurate monitoring in an ICU setting, pre and post-op or intra-op use for that, and then diversion from urinary incontinence for pressure injury and pressure ulcer care, and then end of life care and comfort care. So those indications, and then obviously, if you're worried about urinary retention, get a bladder scan and try to kind of delineate if this patient's having symptoms associated with that. Any other pearls or anything else you'd like to discuss, Dr. Duggan, before we end this video?
Unless they have ascites, which you taught me today.
Yes.
And affect the bladder scan volume.
Awesome. Well, thank you all for watching, and we look forward to seeing you on our next video in the FASTX geriatric curriculum here. Thanks.